Welcome everybody to the, I guess, the 2022 webinar series for the Florida Foot and Ankle Fellowship Society. This is a society for the fellowships in the state of Florida who have opted to get together and share knowledge and share experiences and to provide a common society to get together and continue with education. This is unique because we're partnering with the FPMA, which is our state society. And basically, the FPMA has a 501c3 arm that's for educational purposes called the Florida Podiatric Medical Society. So we're between the three of us, we're trying to improve the state of education in the state of Florida for fellowships. And this is a good mechanism to allow us to do that. And the best part is that we get a lot of different groups together to all go for a common goal. Let's go to the next screen. So our mission is to, as we said, grow fellowship training. As you all know, fellowships are becoming more popular nowadays. People are requiring or requesting additional training or more specialized training, or to just supplement their existing great training. There is a lot of great training in the state of Florida with a lot of the residencies here. But people are looking for a little bit more of that guidance and a little bit more in office and more specialized training, and this allows us to accomplish that. Next. So let's skip through this one so we can kind of get to the meat of our subject here. So these are some of the participating programs, and because obviously there's not 12 fellowships in the state of Florida that are part of this society yet. Hopefully there will be at some point. We've also added some guest fellowship speakers in the future, and you can see them listed here, and they're also listed on the FFAFS website, which is underneath the FPMA website. So if you just search Google for a Florida Fellowship Society, you'll probably be directed to the correct website. Next, please. So this is the Roundtable of Excellence, basically trying to showcase each fellowship and what they can bring to the table, and their fellows, give their fellows an opportunity to speak, as well as their directors. And we think this is a good venue for them, and also to promote, just the increased awareness of fellowships in the state of Florida. And we're very grateful to have sponsorship from different companies. We purposely, and I was saying this earlier to Sean, we purposely match a non-relevant partner or sponsor to a topic for transparency and to show that we're not being biased, or we're trying not to be biased with our educational materials. Next slide. So thank you. And then for this week's roundtable, we can go to the next. Yep, thank you. This week's sponsor is from Organogenesis, and we have Sean here representing Organogenesis, and we'll give them an opportunity. But I just want to say thank you very much for helping to sponsor through an unrestricted grant, I believe, this type of sponsorship. And we're grateful for you allowing this venue to happen. So Sean, take it over if you want to give a couple words and do your thing.
Yes, absolutely. Thank you, Dr. Bellis. So it was, kind of a year in the making where we've gone back to having some discussions about how we can help support this. And so I'm very happy that we were able to figure out a way to do this, and get other industry partners to jump on board. So we are definitely, in the same camp with you guys as far as education, residencies, programs, fellowships, doing whatever we can from an industry perspective to try to make sure that people that are coming out and starting practice are very well educated from our standpoint in the wound care perspective. And we do have some surgery as well. So with that, Alessia, I think I can share my screen. Okay, so let me just hit this real quick. This is just kind of a brief 10-minute kind of overview, but to stay with the theme a little bit, this isn't about going into each one of the products and breaking them down for you guys and going that, that's more of a sales call. I'm not in sales. I'm the director of medical affairs. And so what we do on the medical affairs side of the company is we provide education. So we'll travel the country. I actually have 2 Barry grads that are MSLs for me now. We travel the country. We do educational programs speaking about, the data behind the skin substitutes, really how the skin substitutes work from a mechanism of action standpoint, so that doctors feel like they have a better understanding of how to utilize these types of products in practice to get better outcomes. So with that, this is going to be a very kind of watered down version of that, but I just want to kind of run down, what our thought process is at Organogenesis. When it comes to wound care, everybody understands the 4 phases of wound healing. But what we really are starting to understand through different research publications and different projects that are going on is what is really happening at a cellular and molecular level within these phases. And when patients show up with a diabetic foot ulcer or venous leg ulcer and that wound's chronic, what exactly is happening, and then how can we modulate that? So one of the things that's happened over the last 10 to 12 years is people have really started to understand biofilm. All wounds come in are contaminated, they're colonized, but when they really start to quorum sense, talk to each other, they can be polymicrobial, biofilms. The biofilm is causing a huge issue for these chronic wounds. And a lot of the data is showing that, anywhere from 60 to 90% of chronic wounds possess biofilm. So, it's one of these things where we like to say the majority of chronic wounds coming through the door have biofilm. And so we know that biofilm is the issue. And we know that after a debridement, biofilm can reform within 24 to 48 hours. And so you send the patient home, you're seeing them on a weekly basis, the biofilm reforms, and we continue to have this progression where the patient remains in this kind of chronic inflammatory state. And so if you take it a step further, and this is what I'm talking about, cellular molecular behavior, the biofilm is the main issue that we're dealing with a lot of times with these wounds, but it's the downstream effects of biofilm that are causing problems. And when I say downstream effects is because we have biofilm in the wound, we have increased inflammation. We get all these neutrophils, all these macrophages coming to the area, trying to kill the bacteria in the biofilm, which they can't do because those bacteria are protected. So when you have all of this inflammation in the area, those white blood cells are also producing matrix metalloproteinases. So we get elevated proteases. So the downstream effect of biofilm is increased inflammation, increased proteases. And when you think about those enzymes, they're breaking down the collagen within the patient's wound. They're also breaking down the signaling molecules. So any growth factor cytokines that can be useful in getting that wound out of the inflammatory phase into the proliferative phase, they're breaking that communication down. So when we have biofilm and we have this issue and it keeps coming back and we end up with this increased inflammation, increased proteases, the wound stays stuck in that inflammatory phase, makes it very difficult for them to show an area reduction week after week after week to where they're closed. So one of the first things we wanted to do after we've had Apigraph on the market for a while, when we started to understand biofilm, is put a product out that can help these wounds get out of the inflammatory phase. So this is not replacing debridement by any means. Debridement is absolutely critical. But after a provider does an aggressive debridement, takes the biofilm out, sends the patient home for a week, a product like Purify Antimicrobial is designed to protect that debridement, to keep the bacteria from coming back into the wound, binding to the surface, reforming a biofilm, and in a time period, probably about 3 weeks, 2, 3, 4 weeks, somewhere in that time period, what you start to see is a decrease in inflammation and a decrease in proteases. And so the way that Purify AM works is we have this native structured extracellular matrix. It's coated with an antimicrobial, which is PHMB. And the bacteria, after you've done a debridement, bacteria have to come back in and they have to come through this ECM and come through this gauntlet, basically, of PHMB to get to the surface and then start to reform the biofilm. The bacteria are killed before they can start that process. So this is how we prevent biofilm reformation with this product. We don't kill existing biofilm, we prevent the reformation of biofilm with this. At the same time, because we have a native structured ECM, we're knocking down protease levels. So the two downstream effects of biofilm we're able to address with this product. Now, what happens is clinically, your patient may start to show signs of good, healthy granulation tissue. Everything looks normal. The exudate's under control. We're just not seeing closure. And that wound is telling you that the body, the patient's cells are not producing enough of their regenerative and angiogenic growth factors to move into that proliferative phase. At that point, If you've controlled the inflammatory phase and you're starting to move out of that into the proliferative phase, that's when you would make the switch to a growth factor product. Apligraf, for example, is a growth factor product. NuShield, Affinity. You've set the wound up now by decreasing the inflammation, decreasing the proteases to where that wound is ready to receive exogenous growth factors, and you're going to get more bang for your buck from those types of products. When you use your growth factor product up front, before you get the inflammation under control and the proteases under control, you're wasting a lot of factor products because the wound isn't ready to receive those exogenous signals. So we look at prognostic indicators, look at area reduction, use the area reduction over time to determine whether or not that wound is moving into the proliferative phase on its own. If it isn't, then that's when you would switch over to your exogenous growth factor product. So real quick, Apligraf, you guys know this has been around for a very long time. Bilayered living cells, produces growth factors. The product does not incorporate, it's not going to revascularize. Nothing from Apligraf gets into the patient except for the growth factors themselves. If we don't set the wound up, then the growth factors aren't going to do a whole lot for you. Right? So it's all about setting the wound up to receive the growth factors. With Apligraf, because of the different pathways through the FDA, we are limited to the only 2 indications that we are approved for through the FDA, and that's for diabetic foot venous leg ulcers. With Affinity, which is a placental tissue, it's a live or living viable placental tissue, we have the ability to treat more wounds because it went through a 361 HCTP pathway. So the placental tissues have a lot to offer. And with this, it goes through a certain processing technique where at Organogenesis, we're really big on viability. This is the processing technique of placental amnion that allows us to keep the cells viable. We don't cryopreserve, we don't lyopreserve, we don't dehydrate this one. We keep it fresh, and it allows you to put on fresh placental cells that are actively producing growth factors. If you are looking for something that's convenient and viability is not your product of choice, or you'd rather have something on the shelf and multiple, different sizes, again, multiple wound types with this, we have a dehydrated version of a placental tissue, which is NuShield, and that allows you a little bit more flexibility because of the convenience associated with dehydrated products. Now, when people ask me what's the difference between a living, placental tissue and a dehydrated placental tissue, the real difference is with the dehydrated products, you start out with a certain number of growth factors in that product, and they start to diminish immediately after application. With the viable products, when you put them on the wound, because you have cell viability, you don't get the reduction in growth factors immediately because you're having active production of growth factors from the viability or the viable cells that are there. So that's a quick overview. I didn't want to get into a ton of detail on the products, but hopefully that gives you kind of an idea behind the thought process at Organogenesis with the skin substitutes that we have. We're not trying to throw, a ton of skin subs out there and pick whichever one you want. It's really kind of a design process that correlates with the phases of healing so that you can use the right skin sub at the right time and ultimately try to improve patient outcomes. So with that, I'll end it up. And any questions? Doctor, you might be on mute.
Sorry about that.
That's okay.
Thank you, Sean. I was just going to say, if anybody has some questions that they think of, maybe a little bit delayed, we can put it in the chat section, and I'll scan that later, and we can look at that point. But I want to say thank you, Sean. Your company is excellent, and thank you for all the educational support you're providing our whole entire industry, especially this seminar series. So thank you again, and we really appreciate your lecture here.
Absolutely.
Thank you. Next up, we have Dr. Kevin Lamb and his fellow, Joe Altepeter. I'm sorry, Joe, could you pronounce your last name, please? Altepeter, excuse me. So I think they're going to be speaking about CT impact on weight bearing, and I think Joe's going to be sharing his screen. And Joe, the floor is yours. Thank you for being here.
Yeah,
and Kevin. Yep.
Can we see that all right?
I see it. You might want to do full screen or
Yeah,
presenter mode.
get into presenter mode. Dr. Lamb, did you have a few words you wanted to say?
Sure. Thank you everyone for joining us. Basically, we're Family Foot and Leg Center's fellowship down in sunny Naples, Florida. We've been in existence for about, I think 6-7 years now. I lost count. So as Dr. Bellis said, more people are seeking out fellowships, and for that real world experience outside of residency. I know residency trains our residents very well as far as hospital surgery and surgery. But I think it's also very important to know how to work up a patient and also deal with any post-op issues that may come up, because in residency you're just used to doing surgery after surgery after surgery. But if you can't talk to a patient or know how to talk to a patient about surgery, you're not going to get them on the OR. So I think that's very important to have that part of training and see how the office operates and see a patient from start to finish, from workup to post-op to finally discharge. That's my spiel.
Great. Yeah, I totally agree. That's been a huge benefit thus far in my training. So we'll get into the presentation here on weight-bearing CT and its impact on today and tomorrow. We'll run through a little historical perspective and go through some studies and then get into a little case presentation here. So how do we get here? Early computed tomography. After the CT scanner was developed in 1967, it was first applied for brain evaluation in 1971 by Dr. Hounsfield and Dr. McCormick, earning them the 1979 Nobel Prize in Medicine. By 1980, over 3 million scans had been performed. And in 1983, the first three-dimensional reconstruction was developed for evaluation of complex craniofacial abnormalities. By the mid-1970s, CT was adapted for evaluation of the foot and ankle pathology, used for various pathology, including trauma, bone tumors, coalitions, and tenograms. Obviously, early on, it was a little impaired based on the computer processing capabilities, but has obviously advanced very much to this point. Simulated weight bearing has kind of been more and more widely recognized, or weight bearing imaging studies of the foot and ankle has been more and more widely recognized as its importance. So studies have attempted to replicate weight bearing for CT evaluation. A recent study in 2018 compiled a list of various methods of simulated weight bearing from as early as 1999. Obviously, none of those are going to perfectly imitate ground reactive forces acting on an individual's foot. But one thing that has really advanced the potential for weight-bearing CT technology is the advent of cone beam technology. So without going too far out of my league here, originally CT scanners used parallel beam technology, requiring many slow rotations to gather enough slices to be reconstituted into a three-dimensional study. The next generation of CT scanners used fan beam technology, which sped up the rotation, but still required many rotations to compile enough for a three-dimensional study. And now cone beam technology was described in the mid-90s and applied initially to dental and maxillofacial surgery, and later applied to orthopedics in the early 2010s. But it essentially speeds up even more the process of acquiring the images, capturing essentially your whole study in one or two rotations. So cone beam technology, again, is really what allowed for the transition from standard CT machines to a more space-efficient weight-bearing CT machine. And these became first available commercially in 2012 and have had many different machines come to the market. The emergence of cone beam technology has also allowed for a decreased effective radiation dose to the patient over the course of the scan, apparently even less than what you would be exposed to on a flight to Europe. Over the course of a 7-year period, which included 13,000 weight-bearing CT studies, this article evaluated those studies, and the authors found a statistically significant reduction, again, in the radiation dose per patient compared to a control group who had conventional radiographs, with about 30% of that population receiving conventional CT scans. And in the same study, there was a significant reduction in time spent by the radiology technician in completing these studies compared to the control group. So why weight-bearing CT? It essentially allows for simulation of your standard two-dimensional weight-bearing radiographic views and measurements, and it can be accomplished in a more reproducible manner. The anatomy is often much more clear when dealing with the CT slices rather than overlap on radiographs. And with a CT scan, you essentially mitigate the projection bias inherent to a two-dimensional plane film. And being in the 3D environment, the foot position for measurement can be chosen and subsequently modified on a weight-bearing CT scan. So those the advantages are kind of depicted here briefly in these two studies. So on the left, you see non-weight bearing, and on the right, you see the weight bearing, how the ground reactive forces can impact the way that you read the study. So these advantages were supported by a 2014 study comparing measurements between non-weight bearing and weight bearing CT scans of the ankle, which evaluated various hindfoot angular measurements. They ultimately found that when comparing CT techniques, weight bearing caused statistically significant changes on most of the measurements they evaluated, significantly decreasing the fibulocalcaneal distance and talocalcaneal overlap, and significantly increasing the naviculocalcaneal distance. They concluded that the application of weight would have considerable impact on clinical and preoperative decision-making. So how can we apply weight-bearing CT specifically to the forefoot? There's been a number of studies comparing forefoot measurements between radiographs and weight-bearing CT. One that I find particularly interesting is this 2015 study that sought to come up with a new reliable method of measuring sesamoid position. The sesamoid position was first graded relative to the crista according to Yildirim, and then further stratified based on the alpha angle, which essentially evaluated the coronal rotation of the first metatarsal head. Here we kind of see how the authors took their coronal slices through the head of the first metatarsal, essentially bisecting both the tibial and fibular sesamoids in the transverse plane, perpendicular to the long axis of the first metatarsal in the sagittal plane. So they ended up coming up with 4 different classification groups for hallux valgus deformity. Group 1 was considered pronation negative and subluxation negative. So the first metatarsal had essentially a normal first metatarsal pronation angle. The alpha angle was less than 15.8 degrees, and there was no tibial sesamoid subluxation. Moving on to group 2, there was pronation negative, subluxation positive. So there was a normal first metatarsal pronation angle with tibial sesamoid subluxation. Group 3 was pronation positive, subluxation negative. And finally, group 4 was pronation positive, subluxation positive. And they ultimately found that hallux valgus deformities had a more pronated first metatarsal head than the control group, with a greater alpha angle. Pseudo-subluxation of the sesamoids existed in almost 26% of their study group, and applied clinically, this can really improve your decision-making preoperatively. Looking at this 2018 study utilizing the weight-bearing CT to evaluate relationships of the forefoot between hallux rigidus and metatarsus primus elevatus using 3D reconstructions from their weight-bearing CT scans, looking at various forefoot measurements. So their primary finding was that patients with hallux rigidus had significantly decreased first to second metatarsal declination ratios, indicating the presence of metatarsus primus elevatus. Here we kind of see their depiction on how they were able to obtain their angular relationships. For the patient population, they also found that higher grade hallux rigidus was associated with greater metatarsus primus elevatus, and hallux rigidus did not correlate with hallux valgus. The inter and intra observer reliability was noted to be very high for this study. So it really shows that these types of measurements can be very reproducible. As far as midfoot and hindfoot applications, again, there have been a number of studies comparing various measurements between standard radiographs and weight-bearing CTs. There's a bunch of different descriptions and depictions of these angular relationships, similar to what is evaluated on your two-dimensional radiographs. I won't run through all of them individually, but I think these, once you kind of combine all of them, you're able to really visualize and generate a really thorough understanding of the way the foot is interacting with the ground reactive forces. So the weight-bearing CT really gives you a good global view. And evaluating some of these, this study from 2016 validated their novel method of assessing hindfoot alignment. So they had 60 malaligned hind feet divided between valgus and varus deformity. Two of the authors measured various hindfoot angular relationships at different time points. Most importantly, the talar shift and the hindfoot alignment angle, but they also had an array of other measurements that they evaluated. On the left, the authors measured the talar shift, which is demonstrated here. It's the distance between the vertical axis and the central line of the talus. So that blue line that you see intermediate to those two green lines is what they measured to be the talar shift, which essentially measures or represents a force vector that the heel is subjected to during weight bearing. And then on the right, we see the author's novel measurement of hindfoot alignment angle. The angle is created by the talocalcaneal bisection from the midpoint of the talus to the plantarmost weight-bearing point of the calcaneus in reference to the long axis of the tibia. One of the nice things about the weight-bearing CT is you're able to generate a simulated clinical hindfoot view. In this study, they, as is standard, they evaluated the bisection of the Achilles tendon in reference to a bisection of the heel. And on the right, we have a simulated hindfoot alignment, or sorry, a simulated long axial view with hindfoot alignment also measured as is standard. And then here we have slices from various CT scans. On the left, rectus hindfoot, centrally a varus hindfoot, and to the right, a valgus hindfoot. Again, noting that they're measuring based on the plantarmost weight-bearing point of the calcaneus. They concluded that this was a clinically relevant and reproducible method for measuring hindfoot alignment using the weight-bearing CT. It demonstrated a positive correlation with previous hindfoot angles based on the weight-bearing two-dimensional radiographs and clinical alignment assessment, and had an excellent reliability. They concluded that the weight-bearing CT scan can be used to objectively measure hindfoot alignment similar to plain films, if not superior to them. And again, there's various other methods described for measuring the hindfoot alignment. There's more advanced three-dimensional biometric measurements described, which we'll kind of jump into a little bit here in a minute. As far as I know, the only validated or proven superior for decision-making purposes measurement was that study that we just went over. So jumping into biometry, a somewhat controversial topic that we won't go too far into depth on, since it's been quite a few years since I've taken any kind of statistics class. But biometry is defined as the application of statistical analysis to biological data. In the realm of weight-bearing CT, the goal of 3D biometry is to create algorithms based on statistical analyses to eventually develop software for automated measurements. And to my knowledge, these algorithms are still in the early stages of creation, but they utilize voxels, which are defined on your XYZ coordinate plot, and they define a biomechanically relevant space from which anatomic relationships and measurements are assessed. So here we see the application of 3D biometrics for hindfoot alignment. This study kind of indicates that they're showing a lot of promising results. This one was from 2021. The volume used for measurement was created by the 3 weight-bearing surfaces of the 1st and 5th metatarsal heads and the weight-bearing surface of the calcaneus. And these were evaluated in reference to the midpoint of the talar dome. The 4 points are the voxels on the CT scan that eventually create the biomechanically relevant space, which is processed using software built into their CT machine to generate their quote unquote foot ankle offset, which is essentially the offset of or shortest distance between the hindfoot to forefoot midline and the midpoint of the talus, as represented in that three-dimensional schematic there. The offset in reference to the length of the foot creates the foot ankle offset, which theoretically represents torque that could be produced at the ankle while it's going through gait. The authors evaluated 135 data sets, including 57 normal, 38 varus, and 40 valgus hind feet. The foot and ankle offset is expressed as a percentage, which mean with a mean of 2.3% in the normal population. In the varus cases, the mean was about negative 11.6%, and in the valgus cases, the mean was about 11.4%. So with these 3 groups having statistically significant differences, they were able to show that the foot ankle offset was something that could be evaluated by multiple different observers and had a high reliability. The foot ankle offset has also recently been retrospectively evaluated as a predictor for concomitant procedures in total ankle replacement. The foot ankle offset positively correlated with the occurrence of additional procedures, with a valgus hindfoot requiring a greater number of additional procedures, having a nearly 2-fold greater chance of having a calcaneal osteotomy. So the authors of this study felt biometrics could continue to enhance preoperative assessment and surgical planning. So from biometrics, we get to artificial intelligence with the advancement of the weight-bearing CT technology. There are studies underway evaluating the performance of artificial intelligence generating measurements based on these studies. One such study from this past year evaluated the performance of artificial intelligence in the measurement of the intermetatarsal angle formed by the 1st and 2nd metatarsals. 128 feet that had undergone weight-bearing CT were evaluated, including 59 with hallux valgus and 69 controls. Manual measurements were taken by the authors at different time points, as demonstrated on the left, and these were compared to the artificial intelligence software generated measurements from a 2D model and from a 3D model, as demonstrated on the right. The differences between the control and study were statistically significant for each measurement method. Statistical analysis also showed strong inter-method correlation between the three methods that were statistically significant. And there was excellent inter and intra-observer reliability and nearly perfect intra-software reliability. Interestingly, the software generated both the 2D and 3D measurements in a total of about 14.5 seconds, while the single manual measurement took about 23.6 seconds. Another recent study retrospectively reviewed 34 Cabo Veris data sets and 17 normal data sets. They analyzed the foot ankle offset, calcaneal offset, and hindfoot alignment angle using dedicated software. They had the intra and inter observer reliability for all measurements were excellent regardless of subgroup or deformity. So this was another study supporting the efficacy of at least semi-automatic measurements based on 3D biometrics. Obviously, this is a relatively controversial subject in kind of giving that the responsibility of making these measurements and making clinical decisions based on your own measurements versus passing it on to a computer to do that for you. And as far as the future of weight-bearing CT, what is on the horizon, look forward to seeing some agreement on reference points for measurements. I think that'll be important for reproducible studies and evaluating efficacy. At some point, weight-bearing CT, I think, is going to become first line for preoperative workup, replacing the process of acquiring plain films prior to CT studies. There's also been quite a bit of vendor integration underway at this point with engineering of templating, cut guides, and customized implants. And I do think user-friendly software will become available at some point that kind of easily spits out automated diagnostic and prognostic information, as well as therapeutic solutions. So getting into a case now that I think showcases a lot of the advantages of weight-bearing CT. This patient actually came in earlier this week. And fortunately, we were able to get authorization for a CT scan pretty quickly and actually got that done this morning. So this 31-year-old, 6'4", 320-pound gentleman who played collegiate football before going overseas to play professionally. His past medical history is only significant for hypertension. He had flat feet all his life and did not have significant problems until he began working a warehouse job recently. He sought medical advice and was diagnosed with a talocalcaneal coalition, and he later underwent surgical management by another provider about 6 months ago with resection of the tarsal coalition, subtalar joint fusion, and Achilles tendon lengthening back in July. Upon presentation to us earlier this week, he had complaints of progressive pain to basically the entire right foot, most significantly along the Achilles tendon, lateral column, and hindfoot, and to the first MTP. The vascular exam was grossly normal, with the exception of significant medial and lateral hindfoot edema on the right side. He had a well-healed scar along the medial aspect of the right rear foot, anatomically consistent with a talocalcaneal coalition resection, and there was no concerning neurological findings. Clinically, the right hindfoot was in a rectus position, while the left was in valgus, with the right forefoot supinated and a flexible midfoot. He He had tenderness to palpation along the right Achilles, sinus tarsi, medial and lateral hindfoot, and along the plantar aspect of the lateral column. He had tenderness with manipulation of the right subtalar joint, although no appreciable motion, and less so to the first metatarsal phalangeal joint. The muscle groups were all strong, with the exception of active plantar flexion with tenderness to the Achilles. So on the foot films that we obtained, he had a slightly narrowed first metatarsal phalangeal joint and somewhat increased soft tissue density laterally. Otherwise, the foot views were fairly unremarkable. On the lateral view, attention's immediately drawn to the subtalar joint, which is still quite visible with two traversing screws that seem to be in good position without surrounding lucency. On the Mortise, again, the posterior facet and sinus tarsi are clearly visible and hardware appears to be in good position. On the AP ankle, the ankle joint is preserved. The talus appears to be rectus. And again, the hardware seems to be in a good position. So the next part of the workup for this gentleman is, of course, a weight-bearing CT scan. So one of the nice features of having the weight-bearing CT scan in the office is the ability to add and subtract soft tissue layers and remove whatever bones you need to visualize what you're trying to see. I could have done a little bit better of a job here, but hopefully you can appreciate that the threads of that medial screw are unfortunately not purchasing any of the calcaneus. Again, you can see that here on these coronal slices. You can gain a lot of information of the placement really from various angles. Again, here, a simulated hindfoot alignment view. You can again see that medial screw is sitting pretty medial and not really hitting any of the calcaneus there plantarly. Evaluating the subtalar joint, there's really no appreciable bridging along any of the talocalcaneal articulations. Unfortunately, I forgot to snap a good frame with the lateral talocalcaneal angle, or the talo-first metatarsal angle rather. But looking at the simulated sesamoid axial view, you can easily see that the medial column on the right foot is sitting much higher off the ground than the left foot, and much higher than the ipsilateral fifth metatarsal head. And again, looking at these slices through the mid-substance of the sesamoids, you can see, again, the difference in the sesamoid height from the weight-bearing surface. Another cool yet not always applicable feature is the ability to look at the footprint, which you can see a pretty significant difference between the 2 feet. While studies thus far have shown fairly poor correlation between pedobarography and weight-bearing CT, I think you can see a change in the skin tension along the right forefoot, which kind of clues you into what is actually contacting the ground. So unfortunately, this guy is going to have to go through another surgery addressing the right foot. I think the weight-bearing CT in this case is extremely useful, giving us diagnostic information, a surgical and biomechanical factor that put him at risk for a non-union, and information on what kind of deformities need to be addressed in a revision reconstructive procedure. So a good resource for more information on weight-bearing CT is the International Weight-Bearing CT Society. Their website has a nice list of relevant research from as recent as May 2021. So thanks everyone for joining us tonight. Thank you, Sean and Organogenesis, for sponsoring this event and supporting the Fellowship Society. Thank you, FPMA and the Foot and Ankle Fellowship Society, for organizing this lecture series, especially Karen Lambert, Dr. Perler, and Dr. Bellis for organizing and orchestrating these lectures. And if there's any questions on the topic, Dr. Lamb and I would be happy to answer.
Great, thank you, Joe. I have to say, this is kind of exciting for me. I know it's Xray, and we're not always excited with Xray, but this is like going from an old phone to like an iPhone. I mean, this is really a cool technology. And from a documentation standpoint, I have to agree. You know, many of these, I do a lot of work comp, and frequently they like to see an independent CT, MRI, or whatever be done that can confirm that actually there's no bridging across that fusion site, or there is. And so I think this is a really cool, and I wish I had one. I don't have one, but this is a really cool technology that I think that eventually we should all aspire to have at our practices. So great job, and I'm kind of jealous that I don't have one of these, and I really want one. I guess there's a couple questions that I'd like to moderate here, if that's okay. A couple of process things, and then we'll get into the financial questions that they're there. One of my questions was, how long does a scan take to perform? And then, do you need dedicated staff, and is there special certification?
So Dr. Lamy can answer if you have any disagreements, but our radiology tech, as long as you're a certified radiology technician, which all of our medical assistants are, you're able to have them perform the exams. And the exams themselves take all but 2 or 3 minutes of the patient standing in the machine. So they're pretty quick and efficient.
As far as certification is concerned, for the office, we have to go through IACT, one of those organizations that certifies our center as an imaging center for CT scans. So we had to get lead line walls and stuff like that to comply, and get a physicist to come out and visit us every 2 years. And me being the medical director, I have to take those specific CMEs for the CT scan every 2 years in order to keep it certified. So there are some things that we have to do, but the company is really good at guiding us through that process. At CME, we all have to do it. So.
When you do a CT, I guess, how long does one CT take, and do you take always bilateral, or is it unilateral? And then when you need to get approval, is it approving it for both or just for one? Could you go into that a little bit?
From a practice management standpoint, and also from reality standpoint, I mean, when we're doing weight bearing CT scan, we definitely want them. We definitely scan both, because you're stepping into the CT machine with both feet. We want them to be weight bearing at the regular angle basic gait. So that doesn't defeat the purpose of the weight bearing scan and what we're trying to look for. Let's see. When we're getting authorization for private insurances, we found that they typically will only authorize one versus the other. They'll typically authorize the one with the problematic side. Very rarely to authorize bilateral. But you know, for some insurances, they'll allow you to take bilateral as a comparison, et cetera, et cetera, et cetera. But I would say 99% of our CT scans will have bilateral in there. Whether the radiologist that we contract to read them reads both or one depends on the order that we write and the authorization that we get. So while we may not get paid for both, the scanning is the same, the cost is the same to us, except, you know, the difference in cost is what side the radiologist read. Either they read unilateral or bilateral. That's where the cost difference comes in to us.
How long does each scan take, and how many do you think you can do in a day or in a week? And how many makes it like a break-even financial scenario?
I mean, the scan takes about 2 or 3 minutes. It's really quick once you train the right people and you're there. The scan to break even a month. I mean, the lease is about $3,000. The cost, the profit is about close to 3. So about 10 scans a month, which is not bad.
That's not bad. Okay.
Assuming that you have doctors in your group that will utilize the CT scan. That's one of the biggest complaints I hear from doctors who have the weight bearing CT scan. Is like, I can't get my doctor to use it, because a lot of residents in residency think of CT scan for different reasons than we do. You know, we're using it for preoperative planning, et cetera. We're using it more than I would say that you would use in residency, because you're not getting a weight bearing CT scan. There's more utilization for us because it's weight bearing.
Do you think it made a big difference in your practice structure, or did it impair patient flow, or how do you think it integrated, and was it a difficult integration?
Beyond the initial accreditation, learning process, integration was fairly easy into the practice, into our practice protocol. It's fairly easy. Timing wise, I would say it's not, imagine you have a patient with bilateral problems, foot and ankle, and I'm sure we all have those since we take care of pretty complex patients, all of us on here. Imagine taking 12 views, foot, ankle, 3 views, foot, ankle, 3 views. That takes a lot longer than having a person stand on a CT scan for 2 minutes, and you get a lot more information. They also give you scout images. So sometimes, we'll use those scout images at when we compare size, or we use them as actual X-rays to view the patient's pathology. Instead of taking 12 views, we use them as X-rays, and we get more information out of there.
Do you bill for those as X-rays by themselves, or it doesn't qualify?
They would qualify for X-rays by themselves, yes.
Okay.
Because they are actual digital images of the particular views, and they're very clear. And they're actually better. Calcaneoaxial, sesamoidal views is so easy, so easy.
Hey Kevin, it's Adam Perler here. Do you find that you could use it as an X-ray replacement? Like, would you scan everybody that comes through the door that you would do an X-ray on, and then if you find justification on the 2D view, obviously you build 2D view for that or X-ray view for that. But if you find justification, then go back and get the justification, get the CT, and then rerun it as a CT?
I would say rerun it. I know somebody that does that. I know that somebody that does that exactly how you explain it in the practice. We don't do that at the protocol. We use it only, we deemed it absolutely necessary so that we don't run up those numbers. But once you scan them one time, it's set as permanent record. Once you scan the patient, it's permanent record. So you can't scan them and then rescan them again and erase the first scan. It stays as a permanent record. I guess one of the requirements is it has to be a permanent record somewhere. So we're not allowed to erase any studies and just say tomorrow after we get the authorization, we scan you again. So no, we can't do it that way. But can it replace a regular film and you just use as a regular film? And some people do. We don't unless we're doing bilateral. We're doing a complex case and we know we got to do bilateral and total 12 views. Then we're like, okay, just get the CT scan. We'll take the loss and we'll read the scout and we'll have the benefit of the CT scan.
And I just want to point out a logistical thing. I'm about 2 hours away from Kevin, and he's one of the few docs in the state of Florida that actually has a weight-bearing scan. And I identify patients that will definitely help me make a clinical decision or surgical decision if I get a weight-bearing CT scan. So I actually have them go see Kevin as a second opinion, and he scans them for me. So I'm hoping that you're okay with that advertisement, but it's such a great tool that I actually have patients drive 2 hours each way to go get it so that I can make a better decision. I really appreciate that Kevin has allowed for me to do that in my practice.
Well, you're quite welcome. It's actually great because our fellow gets exposed to more pathology and the patient gets a second opinion. So it benefits everybody,
Yeah, and I'm like Andrew. I would love to have this, and I've gone over this with my my boss several times, and it's been like talking to drywall. It's been very difficult conversation. I can't really understand why, because or at least I do so many CT scans at this point. But that is a different, definitely a I guess a practice decision. I think the larger podiatry groups or busier orthopedic groups, it is something that I think we'll start to see come into. And then the other, potential setup is maybe a group of doctors, if they're in different groups, if they all decide that in that community they would benefit from it. There's nothing saying that you can't go purchase a unit and stick it in a neutral site and all have equal ownership and just kind of utilize it because you're using your own CT scan, even if you're part owner. So that's another potential if anybody on the call had interest in having access to one. And I think from a fellowship viewpoint, you're exactly right. There's no better teaching method than to really critically view your patients before surgeries, but also after surgeries. We never get CT scans in general on patients after surgery. And I did a trauma fellowship in Germany, and they had intraoperative CT scan, which was amazing. And they would fix a calf fracture, and then they bring the scanner and scan the patient and be like, "Oh, there's two screws that are out of position," and they'd quickly reposition them. So this has been around. I mean, now I did that fellowship 20 years ago, and they had that, and it was a 2-minute scan in the OR. So it makes me wonder why we haven't used it more than we are currently using it. But I think the future's pretty bright for it.
Yes, and financially, it's not bad either if you have the doctors with the right mindset in your practice, to be able to use it.
Hey, Kevin, I have one more question. What, clinically speaking and surgically speaking, what was the top 1 or 2 things that you changed about your clinical practice or your surgical practice since adding the weight-bearing CT? What do you think made it better? What about it made your practice better as far as choice of procedures, or what pathology you find that it really does a great job helping you with?
Initially, when I first had this machine, the pathology that helped me the most is we get for some reason around that time we had a lot of revisions for arthroresis procedures, and we're able to get the scan and say, okay, well, this implant would work if it was a little bit bigger, a little bit smaller. So we were able to see the weight bearing on this arthroresis device, and we can say no. That arthroresis is the best it can do. We're gonna go ahead and do a real flat foot procedure now. We use that a lot in that regards. As far as arthrodesis, etc., it definitely helps us to plan arthrodesis. And from the ankle standpoint, as you can see from one of the slides, it's different when you're doing non-weight bearing CT on the ankle versus weight bearing CT on the ankle. I mean, we take Xray weight bearing, so why wouldn't we not take CT scans weight bearing? It really helps us with our surgical planning, definitely. And I know from some of Dr. Perlo's patients that he sent down, we love seeing them because we get to see these advanced pathologies too from Dr. Perlo. So it definitely adds to our fellowship. Thank you, sir. We're able to see the impingement laterally, and we're like, hey, that's the exact problem. How much you have to file down, So
my next question. Oh, sorry.
Oh no.
Go ahead.
Well, from the standpoint of ankle replacement, I know doctors that like to do a lot of ankle replacement. That definitely helps them out, and revisions, etc. Because on a plain film, you're like, oh gosh, it looks perfect, and then on a CT scan, oh crap, that's the impingement right there. So it definitely helps out for doctors who do a lot of ankle replacements.
Thank you. I was going to say I really would like to get Joe's opinion. You're a new practitioner. It's a new device, a new type of modality. Joe, what do you think that? Well, number one, I think Adam asked, will you get one when you go into practice? And number two is, what do you think the best use or the best benefit you've seen with using that?
I think it would be a matter of having enough patient population to support using it. Obviously, like Dr. Lamb said, it only takes 10 patients a month. So, that would be an awesome thing to have in my own office in the future. As far as best application, I think it with the device that we have, looking at bilateral the bilateral studies, you're able to compare the different sides and kind of really evaluate what the differences are, those angular relationships. I don't know if there's necessarily one specific pathology that it's most important for, but like I said, it does give you a great global view of how everything is reacting with the ground.
Okay, great. And Kevin, how many? I'm sorry. Go ahead.
I was going to say, this is Adam again. Joe, I just wanted to commend you. Your presentation was excellent. I really enjoyed that because I didn't really know a lot of the history behind it. I've gone to a lot of the different booths, and I encourage everybody, if you haven't gone to any of the weight-bearing CT scan vendors, definitely go and do that. And what's around the corner, and I think Joe kind of mentioned it in his lecture, is the vendor integration. We're starting to see that happen where a lot of the total ankle companies now have automatic uploads from weight-bearing CT scans, and that certainly helps with surgical planning. If you're doing any sort of 3D printing, it's a must to get bilateral CT scans, because a lot of times you take the deformed bone that you're trying to fix and you're taking the chirality off the other side in that shape. So the bilateral study is great. I think we're going to start to see a lot more. So most people think, well, if I'm not doing complex rear foot and ankle, why do I need one of these? I think what you're going to find in the coming years is there's going to be a lot more applications that impact the forefoot. There's going to be a day and age where you don't even have to cast for orthotics, because you can get a weight-bearing CT scan with the patient standing in their shoes and basically build an orthotic off of the shape of the foot, because they can extrapolate out to the skin. And there's a company in Europe that's doing that, and they're bringing that technology to the US here shortly. So we're going to start to see a lot of applications, even AFOs. Like, you don't have to cast for an AFO, because you can have the patient stand. You could see exactly what you need to do. I don't know if anybody's familiar with the company called DSOR, but DSOR and Paragon 28 merged, or actually Paragon purchased DSOR this past week. And DSOR is a surgical planning software, kind of like Bone Ninja. And what it allows us as surgeons to do is not only upload our CT scans, but now you can start to surgically perform a cut through a bone and shift the bone and see the impact of the position on the foot. And I think what we do is just going to get more and more accurate as we go. So I do see a future where weight-bearing CT scans start to become the normal, kind of like when phones first started coming out, and some people had them, but a lot of people didn't. And then all of a sudden everybody had them, and then phones just got smarter and smarter. I think that's what we're going to see. And then at some point, the integration of Google Glasses, where you can put on your glasses and actually bring the CT scan up in your vision while you're operating. I mean, that's where we're going. It's really exciting stuff.
Yeah, I agree. It's very exciting. Are there any more questions for our speakers at all? If not, I do want to give a little bit of a plug to the number one, to Organogenesis. So thank you very much for the support. Number two is I'd like to give a plug to FPMA. And number three is I'd like to give a plug for our next meeting, which will be, I need to look this up real quick, February 17th, 7 p.m. to 8:30. Dr. Perler will be speaking, and his webinar is in Innovations in Foot and Ankle Surgery and the Surgeon as an Innovator. So obviously, Adam's no slouch to the innovation world. So I think it'll be an exciting and a great next webinar. And I'd also like to thank FPMA for their support, and Karen especially for everything she's doing to help our society improve, as well as the educational arm of FPMA, the society. They're really they've taken this under their wings and helped us with this process. So, Adam, do you have anything else to add?
Yeah, I just wanted to say I wanted to thank everybody for turning out tonight. Also know that if you know people that were wanting to come and view this, all of our monthly meetings are posted on the Florida Foot and Ankle Fellowship Society site, so you can catch all the lectures that we've done so far. The other thing is this series is really for you. So if there's anything that you would like to see changed, or any topics that you would like for us to cover, please feel free to chime in. We're actually meeting as a group next week at SAM, and we're going to be kind of talking about how we can really expand on this series. So this is our first go round with it, and we're learning as we go. And I appreciate everybody kind of hanging in there with us. And also, one final plug is help us spread the word about this. This is a free series. If you have reps in your area that are just learning foot and ankle, these are great series for them to tune into. So it's open for industry, it's open for residents, it's open for students, or anybody out in the community who's practicing that just wants to kind of learn more. And it's free. That's the best part about it. So we appreciate everybody's support, and we look forward to seeing you guys in the future.
Yeah, I concur. Thank you, everybody. Thanks, Kevin. Thanks, Joe.
Thank you. Good night.
Good night.